Okay, well, good morning everyone and welcome. This is our first attempt to have an open board meeting. Our last one was on the 26th of February of this year, 6 months ago, and obviously there's been some very difficult times in between. Obviously this meeting is being recorded and it will appear on YouTube later on, but I'd like to ask Warren, our Trust Secretary, to explain how the public can access that and how it will be recorded. Warren.
Yeah, so we will shortly, within the next few days, publish a link from the usual open board papers section of the Trust website to the YouTube channel where the video can be found. And I think it's worth making clear that in addition to the video, obviously standing as a record of the meeting for the public to view, we will take formal minutes as always. Those minutes will capture the essence of the meeting, will be a summary of what is said, and will not attempt to be a verbatim record of the video itself.
Okay, that's great. Thank you, Warren. We then move on to apologies. We got apologies for Simon Jerry, who is non-executive director, Noel Scanlon, executive director for nursing, and we do have Joanne Todd, who will be presenting Noel's papers as the meeting progresses. Then the declaration of interest. Any board member who is aware of a private or personal conflict of interest relating to any item on the agenda will be required to disclose at this stage or when the item occurs during consideration of the agenda. So we just got to note Steve, Paul and Alison as usual. On that note, they will proceed to the minutes of the last meeting, which, as I mentioned earlier, was on the 22nd of February of this year. And what I would like to do, if we can take inaccuracies and matters arising as we go through each of the pages. So page 1, page 2.
Chairman, I have one on page 2, item B, a matter of accuracy. The third line says, but was sometimes missing the richness of the data. It's the clinical record upon which the coding was based was missing the richness of the data rather than the clinical coding itself.
Okay, thank you, Sue. Page 3, page 4, page 5. On page 5, a matter arising, Sue, there's reference to Shotley Bridge and funding. You might want to give us an update on if there is any change since February of this year.
So the main changes, the changes that we've made to the services that are running out of Shotley as a result of COVID, and as a consequence of that, we've agreed that we'll look at a revised clinical model that will inform probably a slightly different design. So the time frame that's outlined in on page 5 will be elongated slightly, and we're doing that in partnership with colleagues in the CCG.
Okay, thank you, Sue.
Sorry, Paul, can you just go back to
Jenny.
page 4?
Yeah.
It's just the pensions that's mentioned there. Has that been resolved? Or?
So the main way that it's been resolved in this year is nationally the annual allowances were uplifted.
Yeah.
So that's taken away the problem that was causing us to be concerned in last financial year.
Okay. Page 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17.
Sorry, just
Yeah.
at the top of page 17,
Yeah.
it has the very first paragraph, sale advice POs of work. It's got Teesside Enterprise Partnership with Local Enterprise Partnerships. It's the LEP.
Okay, thank you, Morgan. Page 18, 19. Okay, and then we've got an action log, and there's a few items on the action log that just be followed up. Item number 6, relating to work service report. I think that's been updated more since then.
Yeah, and it has several iterations, yes.
Okay. Item number 8. Sorry,
That's for me, yeah.
that's for you, Sue.
Take that, yeah.
To appeal to the...
Yes, so there was a consultation that commenced on the 13th of November 2019 regarding the new working models with staff at all urgent treatment centres, including Peterlee. The consultation documents that were shared with staff contained the arrangements that were then in place and a rationale for the proposed changes, and they invited comments from staff to shape a final decision. There were a number of staff consultation meetings and one-to-one meetings with staff, during which proposed shift times were discussed in order to cover the new opening times of the service that had been proposed. Staff expressed some concerns regarding healthcare assistant cover, which in the initial proposal was not covering the full opening hours, it was only covering 12 hours, and they also offered or requested a preference for shorter shifts in order to cover the opening period. This was taken into consideration and was agreed as part of the consultation at an additional cost to the service, and those shift changes were then applied as that service was implemented. So there was a comprehensive consultation. It was acted upon.
That's great, thank you, Sue. Item number 9 was about including conferences in the board assurance framework, but unfortunately those conferences didn't take place because of COVID-19.
Yeah, I think that's right, Chairman. They would have been included had this been a normal year, and they will be in future.
That's great, thank you, Warren. Item number 10, which is in relation to the emergency fund for prioritisation. That's the introduction for Carol.
Yeah, clearly since that board meeting, and I will cover it later on in the meeting, the ED performance has been in excess of the 95% target, which is good, and therefore this hasn't been a particular issue for us. And clearly there's been other priorities whilst the COVID pandemic has been at its height. If I can bring back the evidence to the next meeting, Chair, if that's okay.
Thank you, Carol. And the last one, item number 11, was about the apprenticeship levy retained by the trust. Norman?
So I too will need to bring an update because the amount obviously has changed, and we recently had a paper into execs about utilising some of our levy with our primary care partners. So I've asked for the update, I haven't yet received it. If I get it during the course of the day, I'll update the board if that's okay, otherwise I'll...
Thank you. So colleagues, is there anything that I've missed from the meeting of the 26th of February? If not, then we'll move on to the Chief Executive update.
So a number of matters just to bring to the board's attention. The first is national matters that are affecting the legislation in and around the NHS. It's expected that that legislation will come forward early in the new year. It's unlikely to fundamentally change the way that foundation trusts are established in statute, but it will change some of the infrastructure around foundation trusts and is very likely to herald therefore significant changes for us. The most significant of those is the change to put on a more legal footing the ICS, Integrated Care System, that we operate within, and underneath that be for integrated care partnerships. So the board has been in discussion around these and is influencing that agenda locally and will need to continue to do so. As more details emerge, we'll be involved in the way the governance around those arrangements are shaped, and we'll have opportunity to feed into that. In terms of the further work of the ICS as it's currently constituted, I've detailed some of the more recent work of the ICS Chief Exec community. So just to pick a couple of those out, we are launching in September Talk Before You Walk. It's already launched in the north of the ICS, and this is a change to patient pathways for patients requiring access to emergency care and urgent care, where they're being asked to contact 111 in advance of turning up at ED and urgent care departments. So that has a lot of support across the region. It's being trialled in a couple of places across the country, and Carol will probably touch on this, but it's one of a number of different measures that we've looking to support that continued good performance on ED and the 4-hour target. In terms of the BAME agenda, the Chief Executive agreed a collective promise to the staff across the NHS, and that was shared on a webinar yesterday, at which local authority leaders expressed an interest in having this promise, this commitment, more widely covering governmental bodies within the North East and North Cumbria. Would you like me to briefly share the promise?
Yeah.
So the promise is that healthcare leaders across the North East and Yorkshire are committed to better supporting people from Black, Asian and minority ethnic communities. This includes ensuring fairness for all and embedding a culture where no matter what your race and or your background, your personal experience, either as a staff member or as someone who accesses health and care services, is one that is not influenced by racism or any bias, be it unconscious or not. Our collective promise includes increasing diversity across all levels of workforce, boards and governing bodies, including leadership, underpinned by transparent and fair recruitment processes, introducing yearly learning and development activities for all staff on the subject of unconscious bias and or cultural intelligence, ensuring through commissioning and encouragement that all leadership boards have a programme of reporting, training and development which focuses on workforce race equality standards such as the RES metrics or other locally determined measures. Ensuring feedback mechanisms are firmly in place for all protected groups and can demonstrate specific feedback from BAME colleagues and communities, creating psychological safety. Supporting zero tolerance for bullying and abuse as a result of racism. A programme which recognises the talent and leadership potential of our BAME colleagues. Ensuring our workplace environments support people from all backgrounds. Ensuring all organisations have established staff networks to support listening into real tangible action where this is not already in place. And as you'll be familiar, we already have those networks.
And just on that, Stuart, the report is now being published on the outcome of the investigation to do with Abdullah, the young man who committed suicide. And it's recommending that all trusts should revise their procedures and processes. I'm sure we'll be doing that as well in light of that report.
And clearly we were alerted to some of those issues before the publication of the report, so we have been working through that with us.
Sorry, Chair, could you speak a bit louder?
Yes, we will incorporate accordingly.
That's great. Thanks.
We've also agreed a process for prioritising our capital requirements under COVID, which we've actually done and which David will come on to. We've had some success with that, but we've got most of our capital bids, as have the rest of the North East and North Cumbria, in a system awaiting for confirmation of national funding, but we nevertheless were able to prioritise those against our clinical commitments. The Great North Care Record, which allows us to share clinical records between organisations, we've agreed to put that on a sustainable financial footing so that can continue. Flu testing this year will be particularly important, specifically if we have a second spike of COVID. So we've agreed ramped up winter plans which have recently been tested, and that process of ratification continues over the next couple of weeks into October, including a regional flu board to ensure that anybody who's vulnerable is able to access in a timely manner the flu vaccine, and you'll be aware that nationally that's been more widely available to different groups this year because of COVID. We've been working, as I've described, on the ICS infrastructure and how particularly the people plan will be incorporated into that, as well as how the development of the ICPs will take precedence within the ICS, given that we're such a large geography. We've supported Newcastle putting a bid in for a COVID lab so that we can do more testing locally, and we've agreed a number of planning arrangements for the rest of this year as we stand services up, and Carol will speak to that later. I then summarise the work that we've been doing in both the southern and the central ICP, and you'll note from reading that COVID has clearly been the main topic that both of those ICPs have been looking at, and that in recent weeks standing up elective services that have had to be paused or slightly reduced over COVID has been the key priority. I won't cover that in any more detail unless anyone's got questions on it. Just to confirm that at the last public board meeting we talked about the Flowers versus East of England case around the holiday payments to staff, and we did put a provision in the 1920 account, so that's covered. In terms of our electronic patient record, just to formally and publicly note that we have paused that during COVID with the support of the board for a period of 12 months, so that will pick up the reins on back in April 2021. An exciting week this week because the first cohort of our Indian nurse recruitments joined us, so 7 are already here and 13 are due to arrive later this week, so they will have a period of isolation for 14 days and then have a programme to bring them onto staff, so that's really, really good news. And then in terms of organ donation, we've shared this in the private board, but we've had a reasonably positive report around organ donation, which the details of which are in the pack for you. And Paul, I think you want to just briefly talk about a memorial at the Durham site that is being planned.
Yeah, people remember that last year we did the memorial at Darlington. There'll be a second one at Durham. We might not get it in this calendar year, but we would expect to get it in between the sort of Christmas and start of the new financial year. There's some discussion as to whether it'll take the form of a sort of contemplative piece in a quiet area, which is pretty much what Darlington is, where people can sit and reflect on what's happened and what it means to them, or a more public piece. And the families and the committee are yet to kind of come to some conclusion on that. So we're going to be looking at sites over the next couple of weeks. There's 2 or 3 options that we've got right there, and we need to be careful clearly because there may well be builders knocking around as well at some point over the next few months. But that's basically where we're up to, that we'll be proceeding with designs and locations over the next 3 or 4 months, and I hope to be able to brief you more fully before Christmas where that's going to be.
Thank you, Paul. Does anybody have any questions for Sue on the item she's already referred to?
I suppose it just might be helpful here. I know we've got a bit at the end of the private board. The guidance has come out for the NHS Charities Together funding that's going to be distributed through ICSs and ICPs. It hasn't given us a figure. I think it's going to be something between 1.6 million and 2 or 3. But I think we do need to be aware of that because there's a lot of work now going on between that. There will be that extra bit of money that's going in the pot. It has to be ICP wide, but it may be quite a nice little boost to capital projects or for work with these voluntary community, the voluntary sector and our other partners.
Yeah, I think it will be really, really valuable. So it's just been announced, as you've said, and we're now pulling bids together and expecting that we'll be able to submit those shortly. So whilst it has to be ICP wide, I think what that means is it needs to, that flavour needs to be across the ICP, but it might support different investments on the various different sites that we and the other organisations in our ICP cover.
Yeah.
So very well covered.
Yeah.
Anybody else?
Chair, could I just request that people raise their voices, please? It's very, very difficult to hear at the back here.
All right, okay, Michael. Yeah, so could we all speak up as we begin to present or ask a question? Thanks, Michael, for that. Okay, if there's nothing else, then Sue, can we move on to the Care Quality Commission update?
Yeah, so I'll hand over to Warren on this, if I may. I think just 2 comments to make at the beginning. This is a really important part of the way that we're regulated, and whilst we have been clearly focused on COVID, and in being focused on COVID, we've made some changes to children's front of house services. We've been mindful of this at all points in the background, and we have had some opportunity that's presented, so we've over-recruited to our children's nursing establishment just in recent weeks. So there's some positive news there that supports the 2 outstanding must-do actions. Although in the case of Durham, we did relocate the paediatric front of house service back up onto the paediatric ward so we could use that space for acute respiratory work. We're in the process of reversing that now. So Warren, I don't know if you want to take us through in slightly more detail.
Okay, thanks, Sue. So I think the first thing to say is that just as COVID has created opportunities and prompted thinking for NHS trusts such as ourselves, it has done the same with CQC in terms of their regulatory approach. Clearly they have not been carrying out on-site inspections, but what they have been doing is developing a temporary emergency support framework through which they are targeting particular areas of risk, calling for evidence to be sent to them and having virtual meetings to get further evidence and explanations. They did that with us in terms of our assurance over infection prevention and control, in respect of which they then wrote to us to say that they were satisfied with our assurance arrangements and there were no issues to follow up. They're extending that thinking, and it's still early days in terms of their engagement on their approach, but they are extending that thinking to move away from big set piece inspections towards a more risk intelligent approach using data, which they recognise needs to be improved from the current blood tool in some ways, which is CQC Insights, with a whole raft of screening indicators, to something that is more subtle and potentially involves working with Trust more closely to understand Trust's own data sets and how the data is interpreted and used. But that then would drive more risk assessment in terms of how CQC target not only which trust that they would need to visit, but also which services and areas they would need to focus their attention on. They still want to do that in such a way, though, that it allows them to re-rate services, starting with those clearly that need to be, hopefully, if the evidence supports it, re-rated upwards. But they recognise as well that they need to evolve their thinking so that it provides the opportunity for performance which is going beyond good to be recognised in those ratings. So they're in the early stages of an engagement programme around that will probably continue for several months, and what we can expect in the meantime is a continuation of what we've seen with infection prevention control and a risk-based approach, where if they get intelligence, if they feel they've detected risk, they will engage with us on it to call for evidence and look at how we assure ourselves around it, which I think is a positive development in their ways of working that will be great to build upon. Whilst we haven't formally had the same monitoring processes in place as people have needed to concentrate on the COVID pandemic response around the action plan from the last inspection, we have, as you can see from the table on page 3 and 4 of the report, made good progress in relation to the must-do actions that we agreed. So there were 9 of those. In relation to the 9, 7 of them are complete. So we have updated our fit and proper persons test to cover the gaps that existed at the time of the visit. We achieved our training targets in terms of mental capacity acts of deprivation of liberty safeguards for 2019-20 and enhanced in that year the offering around those areas. The policies and procedures around syringe driver checks and pain assessments and associated storage of medications have been rewritten and approved by David Oxenham, who's our clinical lead for end-of-life care, and have been through the appropriate approval processes. We have audits planned over the remainder of this year to assess compliance with those policies. And we have also, as you are aware, I think, because we'd almost done it at the time that the CQC team was on site, embedded controls around oxygen prescribing, both within Nerve Centre but also within our electronic prescribing and management and administration system. Again, we have audits scheduled for the rest of the year to assess compliance and to get evidence that we've embedded those changes. As Susan alluded to, the two where we're continuing to work relate to paediatric nursing and medical staff in A&E departments. So for paediatric nursing, we have the opportunity to look at how we use the nurses that we've recruited to support something at Darlington that probably won't be the same at Durham, but does address the need for ready access to paediatric specialists for children presenting. And we are moving back, as Sue has said, the paediatric assessment area to front of house at Durham and looking to build upon that. In terms of medical staffing in A&E, as in other areas, we have had some recruitment success since the last open board meeting. We continue to advertise, propose and use a variety of methods such as international recruitment, internal support for things such as the CSER training scheme so that we can develop people internally and developing advanced nursing roles. That's never going to be a quick fix overnight. That's a long-term progression in the right direction, and CQC understand that. With respect to the should-do actions, which are, I remind the board, improvement points rather than issues where there is a risk of any regulatory breach. Assessment is that we have completed, and again, subject to audits and checks that we've embedded these things, 12 out of 23 of those actions, despite the impact of COVID in the interim. We will, from September, be standing up monitoring arrangements again and working our way through all of the outstanding actions and picking up the results of the audits as we undertake them. We've resumed the analysis that we undertake in terms of CQC's Insight publication so that we can map the trends in terms of any indicators that point to risk within the organisation or indeed that point to very, very good performance in the organisation. That work, given that it covers several months worth of reports, isn't quite complete for this meeting but will be complete and brought back here in September. Following collation of the responses to the queries that have arisen from it. I think that's the overall picture to give you assurance that there has been quite a lot of progress despite the fact that our attention has necessarily been on the COVID response and the restart programme. I'm happy to take any questions.
Any questions for Warren or for Sue? If not, Sue, well, first of all, thank you for answering number 7, which was about paediatric nurses. Clearly that's now being resolved, because we did hear at the last meeting we had over-recruited, but it's good to hear that now being materialised. So that's great news overall. That's on the must-dos. Just on the should-dos, and it's just, I was curious, SD6, which was about keeping our staff involved about the financial implications or changes around the trust and others. CQC, we should keep them more informed. That was at a time when we weren't in COVID and finances were a challenge then. But now that we're in the midst of COVID, have we got any concerns being raised by staff that are around finance and resources or anything of that nature?
No, so nothing's been raised, and there's been quite a permissive regime that we've been funded through during COVID, which we touch on in the next paper. I think the big unknown as we sit here today is what funding regime will be introduced in October, so we're only a few weeks away, and we're unclear about the precise nature of the regime, and we don't have details about the amount of funding that will be available to us. But whereas in the first 6 months we've been able to retrospectively request funding for the full cost of our business, including those relating to, specifically those relating to COVID. So we've been kept whole in each of the first 6 months of the year. The arrangement we do know will change from October, so we'll get a prospective amount. And clearly we're working closely with the care groups and the corporate teams, making some assumptions about that and beginning to introduce a different way of running financially the organisation in the next 6 months. So the accountants are pivotal, and David, you might want to just speak a little bit about what the teams are doing with the as business partners with the care groups and different specialties across the trust.
Yeah, no problem. As Susan mentioned there, obviously the first 6 months of the year we've operated completely differently. The response to COVID, we've spent expenditure on COVID where we've seen offsetting underspends in some of the core business. What the accountants are doing with the care groups is getting to a position where we can normalise our run rate, so we understand as we move forward into the second half of the year what is required as we stand all of our services back up. Also what changes we've made in terms of our estate, our infrastructure, and how our services are provided, and making sure we can financially assess what that means to us in terms of our expected expenditure as we move into the second half of the year. Obviously, within there we've incurred additional costs and forecasting costs around testing related to COVID, and also in relation to PPE, which has been absolutely vital and necessary. So again, there's some significant expenditure that we're still factoring into our second half of the year in that regard. Obviously, a lot of service changes going on, so we're reconfiguring some of the A&E departments, also looking at the implementation of expanded SDEC, which has a financial consequence, albeit ultimately we'll see some savings back of house, as there will be reduced bed requirements if SDEC operates appropriately. So a massive amount of work being done in terms of the reset agenda. Probably summarise it at that point.
So I think in terms of, it's probably even more pertinent a question because there's been so much change that's been thrust upon us nationally to how the finances have worked, and we're about to see it all change again. So it underlines even more working very closely with teams, and indeed the executive are meeting with the care groups after the board meetings today to look at the initial plans that we will be putting in place from October onwards, including the financial parameters with it.
That's great. And just because it is a public meeting, SDEC stands for?
Same day emergency care.
Okay. Thank you. Any other questions for Sue? David? If not, then we'll move on to the next item on the agenda, which is the Executive Director's report on COVID-19 management, performance, finance and reset programme.
Yes, so this paper's been written appreciating that members of the board have had lots of briefings as we provided to stakeholders about what we've done since the very beginning of the pandemic. And it's very much a paper that has been pulled together by the whole of the executive. So I'll start speaking to it, I'll then hand over to Carol, but we're all very happy to answer questions that you might have around it. So I think first of all, it's worth noting that we're still in a national major incident. That recently was regraded from a level 4 major incident to a level 3 major incident, which means that there's more regional than national oversight, but doesn't really change the way that we're managing things internally as a result. So we have a gold command structure, and that structure was meeting 7 days a week in the very beginning of the pandemic as we were standing services up, and now meets twice a week, and essentially lots of the other committees and structures that were for operationally running the organisation have been stood down, and that structure, which is comprised of the exec with representation, both clinical and non, from the care groups, is the way that we're running the operational business within the trust. I think it's worth noting that we are also playing into, by nature of the fact that it is a major incident, into a wider bit of planning and operational concern with the local government agencies, so fire, police, the universities, etc. And we do that through a strategic coordinating group. So that happens to match our footprint, so it covers the County Durham and Darlington patch. And what we've been doing through that group in the initial phases was ensuring that we could all stand up services for patients, that we had, for example, all the most appropriate shielding arrangements in place. As we've moved through the different stages of the pandemic, it's now looking at things like what would we do if there was an outbreak within our patch, how would the various agencies deal with those outbreaks, what measures would we put in place, and the wider, more strategic considerations of what is it likely to do for our economy, how do we ensure we get the economy in as good a place as we can. And we know very well, as do our two health and wellbeing boards, that employment and housing and education are the wider determinants of health and have more impact actually on health than the services that we provide. So we're very knitted into that arrangement. The chairman and I literally speak 7 days a week, so that the way we brief within the organisation into the non-executive component of the board is clear through that arrangement. That's been consistent from the very beginning. There's been different arrangements for the non-execs as we've been in the different stages, which have been taken the form of the briefings that are sent to all staff and stakeholders, but also at a point special briefings for all non-executives that I was doing at their height twice a week. We also have a NED who's responsible for such matters, which is Steve. So Steve and I have spoken regularly, and I've updated Steve in his non-executive role, and we're now on once a month meetings, and we time those to be in between the board meetings. So there's a comprehensive way in which the whole organisation is connected to the work that's happening in the local community, and through that the national work, and that we're connected as a board responsible, as we are for the running of the foundation trust.
So just on that, so
yes.
Could you also add in how the governors are kept informed?
Yes.
And the lead governor.
So the governors are kept informed in a number of different ways. We provide the stakeholder briefings into governors, and they get specific briefings as well. And the lead governor attends many of our board meetings and is kept informed in that way.
Thank you, Sue.
So just in terms of trends, we've actually got 4 patients with COVID in our hospitals as of today. At the height of the pandemic, which was around the Easter holidays, we had about 170 patients. So we've seen a dramatic, but very slow, to be fair, reduction over the in-between weeks. The report suggests that there were only 4 deaths in July. That's actually 2 deaths in July, and so far we still have no deaths in August. And as everyone will appreciate, what's happened since March is our ability to test and the treatments that are available to patients with COVID have come on in leaps and bounds. In fact, the R&I work and using research in live time has been phenomenal across the country, and we've really benefited and utilised that internally. In terms of assuring ourselves, COVID has brought new components into the requirements for us to ensure we've got that board-to-board grip, and we've used Perfect Ward and a COVID module that has been developed to ensure that all of the specific clinical indicators that we are required to follow are being complied with, and you'll see from the paper that we have rolled that out to 46 areas And we've got really great compliance with all areas scoring 95% or greater compliance. The infection prevention control team has had so many teams within the organisation, but they've been real stars. The guidance has changed frequently over the period of the pandemic, and they've kept staff right. They've provided advice, they've helped with communication, they've supported us in our endeavours to ensure that during the whole period we have not had any issues for frontline staff with PPE, and that has been quite challenging at points, but there has never been an occasion where we have not had the PPE that we've needed within the organisation, and particularly infection prevention control teams and our procurement teams have been absolutely amazing in that. We've carried out reviews, mortality reviews for all COVID deaths, and over 100 have been reviewed deaths in the period of March and April, and none of those deaths were considered to be preventable. Most, or the majority of cases show really good, very good or excellent care, as we'd expect with something that's new and that we have been developing our understanding of over the period of the pandemic. There have been areas where our treatment pathways have been refined, and some of the reviews have picked that up. But I think that's a credit to the clinical teams who, to a man and woman, have been amazing at being redeployed into areas, being retrained to go into areas that they're not familiar with. It's been really quite humbling to see staff and the way that they've come together. Our levels of engagement within the organisation have probably never been higher, so it's one of those things that something like COVID either causes people to splinter apart or garners people together, and it's very much been the latter in terms of the organisation. We've, throughout the different stages of the pandemic, been very clear about the capacity that we think we've needed against our plans. That's bed capacity, ITU capacity, and the capacity to deliver oxygen therapy to patients. And throughout the whole time, we've been able to manage that really effectively. We have been pushing to increase the oxygen availability at Darlington, the piped oxygen, and we've just recently been advised that that is now going ahead, so that should be in place before Christmas. Not that it causes a problem, but it's just comfortable to know that that capacity is being increased. In terms of staffing, clearly we've had a number of staff that have been impacted themselves and through their families with COVID, but our cases of COVID amongst staff are, as you'd probably expect, reducing. Back on the 17th of this month, we had 416 members of staff who were on sick leave. That was less than the last report to the board, which was a month ago. And of those, 56 were shielding, 75 were self-isolating, and only 35 were symptomatic. The report describes the arrangements that we've had to repatriate staff, so staff that have been moved to work in ward areas in the height of the pandemic are now being repatriated back as we seek to stand up services, and we've got a little bit more discussion on that later on this afternoon. Another team that are worthy of note are our health and wellbeing, staff health and wellbeing team, who again have been stellar in their interpretation of the guidance and their support to staff at what was quite a worrying time for a lot of people, particularly at the beginning when there wasn't a lot known about COVID. So they have really pulled out all of the stops. They've had a lot of staff repatriated into working with them. And as the board is aware, we chose to put our own drive-through testing facilities in for staff. So we've been able to, as soon as we were able to locate the equipment, test our staff through drive-throughs, and we've been able to extend that into staff working for the local authority, including those in, for example, young offenders institutions. And I think it's been a real asset to our local economy that we've been able to have that testing, because we can turn it round quicker than certainly originally the Pillar 2 testing, the national testing, was able to do. we have identified 6 groups that, or nationally these have been identified that are at high risk. So BAME staff, most people would be familiar with, but all of our male staff, all staff who are over 55 with comorbidities, and the report describes the other 3 groups. So what we've been doing is risk assessments for those staff to ensure that the working environment for each and every one of them is safe, and where that is not possible due to the nature of their work, we've been looking at alternatives to ensure that those staff can return back to us. Shielding arrangements finished at the end of July, so you can imagine we've been very busy indeed as we've supported staff who've previously been shielding to come back to work. We are doing risk assessments for all staff, but we prioritise those that are in the high risk groups, and I'll look in Morgan's direction, but we've got compliance across those of around about the 95% mark in each of those 6 categories, so that risk assessment's really out across everybody else. In terms of testing, we've tested a lot of staff, a lot of patients, and we've tested staff and patients both for COVID and for the antibody. It's interesting that in our staff cohort, the antibody presence is about 18%. It's about 8% in the patients that we've tested, albeit we know that knowledge is staff have certainly wanted to know whether they've had the antibodies, but it doesn't affect at all the way that they need to operate either in their personal lives or in their work life, and it's very unclear what the antibody means. It is, however, information that we provide nationally, and we keep these results for a year, so staff are consented when they have these tests, and what it's helping nationally is a picture to be developed, and that's influencing some of the national policies, so it's quite important that those results are able to be shared. I think I've covered PPE. In terms of agile working, I think capitalising on the engagement that we've had from staff and from some of the agile working that we've had to put in place at really, really short notice, but that's been very successful. So I don't think any of us had used Teams before the pandemic struck, but now we can work in a completely different way. People have been very successfully working from home. There's one particular member of senior management who has probably put in more hours working at home than he would have if he'd been within the organisation. Technology allows us to do things very differently. So we've taken opportunity to brush off our agile working policies and enable us to pursue one of the strands of our people matter strategy that the board has seen and approved recently, and give staff options where at all that is possible to work in a very different way, including the use of technology. So that's been quite a big piece of work. Thanks to Warren in this instance for interpreting some of the guidance, but I think it's important to appreciate how it links in so neatly to the wider agile working that we know will hopefully make us the most attractive employer possible. We've touched on previously the way that we've sought to secure assurance, and really none of the arrangements that we've had previously in place for understanding what's going on in the organisation have been stood down. We've still been getting details of everything from infections, serious incidents, all the measures that you would expect. So that's allowed us to do that, but we've also been looking at assurances around the COVID specific, hence my reference earlier to the ward performance. We have, since the last board, which was held in private, got some new risks on the risk register. They're detailed on page 6 of the report, and our board assurance framework we recently revised to specifically pull COVID out, so the board has seen that and has been able to differently scrutinise our response to COVID. Support to care homes and nursing homes has been a significant part of what we have felt morally appropriate to play during the pandemic. So we were one of the first patches to offer testing within care homes that our community teams went out and undertook. We've also been helping care homes with infection prevention control, and on occasion help them when they've had some staffing difficulties. So we've been through that SCG, the Strategic Coordinating Group, and the LRF, the Local Resilience Forum, very much been acting as a system. There's been no organisational barriers to the work that we've been doing, and that has extended into the private and voluntary sector. To give my voice a rest now at this point, because this is a collaborative effort across the executives, if I hand over to Carol, she'll take us through some of the performance.
Thank you very much. So section 4 of the paper that you have has a table in there which summarises performance from over the last 6 months against the key constitutional targets. If I take each of them in turn, starting with urgent and emergency care. So since April, we have been consistently delivering at 95% or above, so therefore meeting the target for 4-hour waits within our ED departments. And the reason for this has been because we saw a significant drop in attendances really from March onwards. We also, has already been referred to, we also changed the way that we were providing services. So our elective programme stopped, which then gave us more bed capacity within the organisation and certainly more workforce to be deploying into other areas. And we also introduced, and again has been mentioned at the earlier on in the meeting, we introduced enhanced same-day emergency care. We also introduced more senior decision making at the front door within our ED departments. And also enhanced our discharge processes, working with the wider system. All of this has then meant a smaller numbers of patients going through our organisation, but those that did go through the organisation passed through our organisation with shorter lengths of stay. All of which then has contributed to a better performance against the ED target. What we've seen though over the last couple of months has been a gradual return in respect of people presenting to the ED department, and you'll see in your report that we're almost back up to 100% of pre-COVID attendances at Durham. But nevertheless, we are still seeing a better performance even at Durham than we did pre-COVID as a result of, again, the elective programme and the changes to the pathways that we've been able to maintain. However, in August, what we have seen to date is that there has been a fall in performance. But when we've looked at that, board members will be aware of a long debate that we had taking place with colleagues in the Department of Health about the counting and recording of ED activity. Well, COVID, I'm afraid, has brought another one of those to the fore, and that is that there has been a shift in activity, so that those people who would have previously presented to urgent care centres are still not presenting to urgent care centres, but what they are doing is that they are accessing the service by virtue of telephone advice. So we are still giving those people, we're still not seeing those people, but we are still treating those people and advising those people. And it's still work that we are doing within our ED department, albeit it is over the telephone. And this activity and it's the same for us as it is for every other trust, who are all experiencing the same. This activity is not captured anywhere, and it is not recorded, and we are not given any credit for it in terms of the 4-hour target. So it's something that a number of trusts are consistently raising, us being one of them, because that would make, again, like our booked appointments issue, would make a difference in terms of performance reporting. Needless to say, we do capture that data, so we do know what proportion of the activity it is, and can supply it at any stage, and are taking the opportunity to raise that in there. If I move on to the elective pathway, so a few things to say about the elective pathway. First of all, the elective pathway was stood down very early in the COVID pandemic, except for emergencies, urgents, and cancers. And we continue to treat those patients throughout the whole of the COVID pandemic. And however, what that did mean is that you will see on the table where it says RTT, which stands for referral to treatment. So the RTT incompletes, which in effect is the waiting list. So our waiting list fell from February through to June, and has then started to increase again in July. The reason for that is that we continue to take cancer patients and those urgent cases off the list, and so therefore the list fell. But also because we had stopped doing routine outpatients, it then meant that there were no new patients added to the list, apart from those urgent that I've referred to. So consequently, the waiting list fell, but it has started to rise again during July as we have restarted most of our outpatient services, but not necessarily to the same pre-COVID levels that we were seeing. And the result of that is that patients are being added to the list. What goes along with that is that the 18-week performance, also, as you would expect, on the back of stopping the elective programme and only treating urgents, what you are then seeing is that the proportion of our patients that were seen and treated within 18 weeks has fallen from the February figure of 86% and is now down at 34%. That will continue to be an area of pressure, because what in effect has happened is that the shape of our waiting list has changed, and as we restart our services and we are still continuing to clinically prioritise patients, then those people who are on our waiting list that are not as high a clinical priority will continue to wait longer. And consequently, we have seen the number of patients who are waiting over 52 weeks have increased significantly to a level that we haven't been used to seeing, certainly over the recent years. Just for assurance to the board, we do clinically review those patients who have been waiting 52 weeks in order to make sure that they are not coming to harm, and if necessary to change their clinical priorities so that they are prioritised and moved up the list accordingly. That pressure will continue for us though, because as a result of the backlog that we've created, the step up of our outpatients, the step up of GP referrals, which although they are increasing are not to pre-COVID levels, and the continuing need for infection prevention and control, social distancing measures, means that our productivity is not as high as it was pre-COVID. So there will continue to be a pressure going forward. We have been required as part of the planning round that Sue has mentioned earlier. We have been required repeatedly throughout the last few weeks and months to submit projections and forecasts for our elective activity programme, and the most recent one was this week. There have been targets that have been set for us on the back of the phase 3 planning guidance, which we received about 3 weeks or so ago, that is looking to how the NHS can increase its productivity. We, at this point in time, our projections and forecasts of what it is possible for us to do are falling short of the requirements which are summarised in section 4 of the paper. So the final submission needs to be in on the 21st of September. So what we are looking at this point in time is what it is that it would take in order for us to be able to increase our performance over and above what we have thought possible at this particular point in time. And we are working through that as I speak. Linked to the elective programme is the diagnostic programme, if I could just jump to that. Because again, what we did on diagnostics, we've always been a very good performer as a trust in relation to diagnostics, but again, routine diagnostics were stood down at the beginning of the pandemic, and apart from urgence again, and they have only recently been stood up and continue to be stood up as time goes on. We have a particular issue with endoscopy, and that is as a result of displacing where we perform the endoscopies, but also that the staff who were employed to support the endoscopy programme were redeployed to support COVID areas. Those staff are now being redeployed back to support endoscopy, but we have built up a significant backlog for endoscopy. We have, as an executive, approved a range of initiatives in order to increase throughput, in order to tackle both the backlog, but also to attempt to keep pace with the increasing referrals that we are seeing as other parts of the programme are stepped up. And so what you will see there is that we are gradually increasing, and so whilst not back up to pre-COVID levels, we are seeing a gradual improvement in performance. And diagnostics is one of those areas that is relevant to what I've just mentioned about, so what else is it that we can do in the short term in order to increase performance in line with the phase 3 planning letter. On cancers, again, as a trust, we are generally a good performer on cancers, but again, we have seen a dip in performance, although not as much as in relation to some of those other areas, because we have tried to protect our cancer pathways, because these are largely then the urgent cases. And so what you will see reported in there is, whilst not achieving the pre-COVID levels of performance nor the constitutional standards, we have not dipped as far as we might have done. And the dip that we have taken has been largely as a result of the endoscopy issue that I've said there, and also linked to other issues around IS sector and access, particularly for breast cancer, which the board is well briefed on, and also again linked to that the necessity for infection prevention and control arrangements. And I think that is probably all that I want to say around performance. I have mentioned the Restart programme, and that continues as we are stepping down the COVID pandemic arrangements, but in such a way that we could step them up again in the event of a second wave. But we need, it is like a set of dominoes. So as we step down one area, it then has knock-on consequences for other areas. So it's not just, it's not as easy to restart as it was to actually step down. And so some areas are a little bit more, a little bit slower. And also we have probably been being cautious and to the point of being perhaps a little bit overcautious, and now we can start. Now that we understand more, we're in a position that we can perhaps take some of those areas a little bit quicker. And the example that I would give would be around outpatient clinics. We have our own board level example of this sitting to my left, of a clinician who will be taking a few more patients into outpatients than we have done to date. Linked to then the restart of services is the embedding of new ways of working, which clearly we took the board through last time in some detail, and that work continues as we work up the business cases, but also slot the jigsaw pieces together of those business cases, and in order to get the greatest benefit within what we expect the financial envelope, both capital and revenue, that will be available to us going forward. And I'll pause there and happy to take any questions that anybody may have.
Thank you, Carol. Any immediate questions for Carol? Steve?
I think just two things, and it was a really comprehensive report. There was reference to PPE, and I think there was an issue with masks and not being able to get the one that we wanted. I just wondered if there was any updates, A, on that, and B, just the comfort that we'll get enough stock of PPE.
It's funny, we've actually got more of the 8833s, which are the ones that were in short supply, so we don't think there's an issue of that at the minute. We do have good supplies and stocks of all kit, and there is another mask that Joanne or Jeremy might remember the name of that we've been fit testing people against, so we've got another product as well. So the idea being that most people will be able to use one of them to fit test standards. We are expecting tomorrow to agree for a very small number of staff for whom none of the products seem to be valid when fit tested, respirator hoods. And we've already got about 80 to 100 respirator hoods, and we're going to be asked to approve another probably about 80, Joanne, is it?
And I think it may not be as many as that, but it'll come tomorrow, I'm expecting
tomorrow. So Gold Command will get a kind of final conclusion on how many respirator hoods do we need, so that means we can keep all of our staff safe, which has always been the case, but it means that we don't have to think about where we deploy them, because we can deploy all staff, clinical facing staff, where they are needed into COVID areas, knowing that for them we have the appropriate PPE, because it's different depending on things like the shape of your face, and some staff, as I say, can't. None of the FFP3s fit them, so they need to go to respirator hoods.
The second question was a much more general question, and it was good to see that all those changes that have been brought in as a result of COVID that have been positive in terms of the way the service is delivered. I just wanted to get the reassurance that the sort of underpinning governance that goes with all those changes is something that that the executive are on top of, and we've got that covered.
It is, so it happens in different ways, but for example, when standing service is up, there's a pro forma that teams have to complete. We've got the reset programme, so the domino effect that Carol described gets quite a level of scrutiny before it even gets to final approval stage, which is at Gold Command. There's also a lot of discussion happening in live time, so when Carol is describing the balance and the domino effect, I think it's more complicated than dominoes, because you pull a lever and 5 different things can happen. So we, as an exec, as well as Gold Command, work together 3 times a week, and I think that's really helped us during COVID. The clinical teams, and Jeremy, you might want to sort of describe some of the constructive challenges that we're making when, to use Carol's description, perhaps we're being a little on the too cautious side, given that our overall responsibility is to do as much work as we can whilst keeping people safe and stand up as much of that elective programme. We're gently pushing and exploring, and our views collectively are changing as we get that better understanding. But I don't know if you want to maybe bring some of that to life around perhaps what we're doing on the AMUs with the low numbers now, Jeremy, and how we got to that position.
So with regards to where we were in March, was there were 2 pathways for everything, a respiratory pathway and a COVID and a non-COVID pathway. We've now stood down the COVID pathways for everything apart from A&E, where there are still 2 streams. However, there is a paper expected either tomorrow or Monday, well not Monday because it's bank holiday, Tuesday, as to standing down the 2 streams for A&E, so because the numbers are so small. So it is a very fluid environment. It's like tides. We've stepped things up rapidly now. Those that with regards to COVID, that is now slowly ebbing back, and we're stepping up the non-COVID pathways as rapidly as we can, taking into account the IPC rules, which, as you can imagine, are extensive.
And I think the way we keep people safe with the small numbers is we can isolate them.
Yes.
So we do what we would if someone came in with various other potential diseases. And in October, if we get the 90-minute test, because at the minute we're typically having to wait at least 24 hours for testing, but if we can test within 90 minutes, that gives us flexibility, because we test everybody who comes into hospital for COVID. But if we can know definitively at the 90-minute point, that is a game changer for how we operationally run things as well. So we're expecting that test to come, but until it arrives, we can't change the clinical pathway.
I think it's very important. The impact of numbers is huge. So obviously in March and April the numbers were very large, and now we're actually struggling to find cases despite massive testing, and it creates its own challenges.
You mentioned staff engagement soon and how good it is. How are we going to build on that? Because that's something we've struggled with for a long, long time, and if we're in this really good place now, how do we, keep that going?
Morgan probably wants to come in, but I think with the People Matters strategy that we agreed last month, that's got all the components in, and it is something that we need to ride on the back of and garner, and there's a whole host of different ways that we've done that and that are continuing. But I guess it's at its core, it's if you like locking in to where we are now. And I think that whilst you say we've struggled with it previously, but we did get quite a good staff survey result last year, which was polled in September last year. So I think we're on an upward journey. We've just had a big turbocharge. And Morgan, you might want to just remind the board of some of the things in that People Matters strategy that we have that we think will be the most fundamental to.
So I think most importantly is in recognising the point you raised, is that we are now in the final draft of a Culture Matters supporting document that underpins the People Matters strategy we approved, that really goes more or less quite some way to identifying the things that you talk about, and that is capitalising on the experiences that have been positive. Sue's referenced already the levels of engagement around pulling together and delivering an outstanding service over the last few months, and clearly we have to be cognizant of the fact that several of our staff may not be able to sustain that level of input and be supportive, and putting in place that recovery as all the health and wellbeing activities are significant. We've also obviously been very aware of the equality, diversity, inclusivity challenges that have been faced by some of our colleagues as a result of COVID and the higher risks, and nationally that's become much more of a priority. We had already gone quite some way to establishing all of those networks, so they're things that we're going to continue as well. Notwithstanding that, we've talked about technology, and a few months ago none of us would have been able to work out how to use Teams and various other technological interfaces. Some of us are still somewhat challenged by that, but nonetheless. But that has actually proved to be a really beneficial way in communicating with lots of our colleagues across what is a very diverse geography of all our estates. So we've utilised that in providing short, supportive meetings, opportunities where we've had changes in policies or procedures, and that has actually garnered quite a lot of interest. So some of these innovations are things we couldn't have predicted before, but have been a positive outcome. So I'll obviously be bringing that back at some point, but that really is just to provide reassurance. We are absolutely on top of that.
I think the interconnectedness, if that's a formal way of describing it, is crucial, and just one little example of how we're more connected and how you can visibly see how staff are supporting each other and communications going up, down, left, right, and in every possible direction is the closed Facebook group. So people have chosen to join that. There's about 4,000 people currently out of our staff who've chosen to join it. And when you're on that, you can see how they're interacting with each other in all sorts of ways. And we moderate it so that if there's anyone who might be in or expressing things where we might think they're in difficulty, we can kind of contact that member of staff. And we've done that on just a couple of occasions, really. But I think that is a live example how, without anything being too orchestrated, just having the platform for communication is amazing. So if you're not in it, you should maybe join just to look at what is transacted over it.
No, that's a really good point, and it has produced all sorts of positive outcomes, and being able to target issues at source has actually helped prevent it becoming a bigger issue.
Michael?
Thanks, Chair. I just wondered about, if you like, the unforeseen consequences of COVID and our responses to it. At the Integrated Quality Committee yesterday, there was a very interesting report about an investigation into the incidence of falls during the pandemic. And the result, the investigation found that things like donning and doffing PPE, the fact that patients are often in closed rooms, the fact that therapy sessions sometimes have to be suspended because of the restrictions around the pandemic, could lead to a higher incidence of falls. The committee was very assured yesterday, A, that the investigation had taken place, and B, that all the appropriate mitigations had been put in place. But I just wondered if there were any other things that the executive were losing sleep over that you wouldn't have foreseen. We've all seen the wonderful work that's directly dealing with patients who are suffering, but it's the sort of unforeseen or unintended consequences that I'm interested in. Anything that making us lose sleep.
I think in the early days, Jeremy and I and various others had lots and lots of conversations, because what was then really difficult for us to balance, and it became easier as treatments for COVID emerged and we were clearer on the numbers, and they were a lot less than we had originally anticipated. But we had many, many conversations about the balance between not standing things down. So we were really clear we didn't want to stand everything down. And Carol's described that some of the good position we're in is because we kept most things going. But that was, we had lots of very, very intense conversations, didn't we? Challenging ourselves to we're going to do the right by everybody, and just only treating COVID and, if you like, suspending everything else isn't the right thing to do. So that is a kind of an older example. I think now we are aware, and I don't think we've seen this, and there's lots of national bodies and charities that are commenting on it. We still know our presentations are low, but we still know people aren't going to the GPs. We know we're not getting as many referrals. previously we didn't think we were getting inappropriate referrals from GPs particularly. So has some of, a number of diseases progressed in individuals who haven't sought help, perhaps because they've been scared, and will we need to deal with them at a different stage, and how do we encourage people to come in to our services because they are safe? And we've been doing lots of media around that. I think getting that message out is critical, and the fact that we can't quite explain why GP referrals are still so far down on previous years is a bit of a worry, but
for me, and it doesn't keep me awake at night, but it is a concern, is the long-term mental stress of all the change. I'm not talking specifically about PTSD before Morven has a slight meltdown on me. I'm talking more about weariness with the pandemic, weariness with constant change, a feeling that people have done their bit, the claps aren't happening anymore, this is becoming normal business, and I think that will become increasingly a problem throughout the autumn and the winter until the pandemic finally dies out. And that is something that we have to be careful of and also guard against in terms of the amount of change that we force is the wrong word, but suggest on stuff.
Any other? Paul?
Christian Calvin there. One of the things, all of the stats are tremendous in terms of what's happened and how well we've performed, but I wonder whether or not there's a bit of a ticking time bomb with NA attendances, in as much as for the levels of activity to return so close to normal when we're hardly really out of what's happening is a bit of a concern. And is there anything more that either we can do to better deal with the thing, given that the capital expenditure on the Durham is some way off now, if ever actually. But equally, whether or not there's an opportunity to work closer with secondary care, whether Stuart could do something, what more could we do that's going to stop the 92% slipping further back, sort of thing?
Okay, there's a number of things to say in relation to that. As a region, we are rolling out the Talk Before You Walk campaign, which would require patients to, through using the 111 system, to contact 111 before they presented at the ED department. It only started in the last month or so in the north, to the north of us, in the North ICP. We are due to be starting it in September in the Central and the South ICPs. If clearly we don't know to what extent that is going to be successful in either people contacting 111 in the first place and then being redirected. Because clearly, as you know, we already had quite a track record on this patch with booked appointments, which was part of our issue that I referred to earlier about the recording and counting of activity. And there are potentially quite large percentages being bandied around about what the reduction might be. I think we need to see what that might be. As I think I said at the last board meeting, this has been a source of concern for me all the way along, because when we have been pressured previously in ED because of the level of demand that we have on our services, in a way, by seeing then how our performance can jump in improvement when the number of attendances comes down, seems to vindicate the line that I've taken and that you've supported me as a board in pointing out that it is level of demand, not necessarily what we do or don't do with those patients, that is the major determinant of our performance. And therefore it is something that I have approached and discussed with our CCG and ICP colleagues about a need to not just restart services, but look at how we can capitalise on demand management into both elective and non-elective services. There has been an initial meeting that both Stuart and myself co-chaired, Stuart Finlay, and myself co-chaired, involving clinicians from the Trust and representatives from the primary care networks, looking at what we might do together. And the discussions were pretty much around pathways of care and greater use of clinical advice lines and advice and guidance, which I think are all good stuff. I'm a bit sceptical myself about how big the numbers can be that could then be redirected elsewhere. So in many respects, I share your concern. I think we are doing what we can do in order to redirect people to more appropriate places for treatment. And what that then means is that the only other thing that we can do, which again are the things that we are doing, which is the embedding of same-day emergency care, front-of-house models for frailty, and those enhanced discharge, which are about efficiency in the hospital, so that then, as and when those patients do present, we can see them and treat them as efficiently and quickly as possible.
Any other questions? Jenny?
For social distancing, that would make a big difference to us. So are we doing the 2 metres or the metre plus? Because we're all having to wear masks.
2 metres.
2 metres. And is that what we're going to stick to, or are we going to try?
That's what we've been told.
Is that what we've been told?
It's actually mandated. It's 2 metres in hospitals. End of.
Right.
Last one.
Okay, so that'll make a bit of difference.
Yes, because that immediately is causing us issues about waiting rooms.
Yeah.
And also links into the issue about the visitors. And people accompanying. So if you came to the ED department as a family outing, well, clearly we've had a rule about it's the patient only. But as we go further through this and things get relaxed and people are then bringing somebody else with them, then it causes increased issues about waiting area spaces.
Right. So do you think they're going to live, or is it just going to remain 2 metre plus indoor?
That is just
certainly the news guidance that came out last week was very clear, still 2 metres.
Right.
Anything else to add from this paper? I mean, as David has told us a little bit about finance earlier on, so I think there's nothing more to add on that at this stage. But I think it's an opportune moment to record a number of thanks, and first and foremost to all our staff who have been absolutely exemplary. I mean all our staff. That's all 7,000 or more across the organisation who have bent over backwards, been extremely flexible, changed roles, changed responsibilities in order to deal with this very unusual situation. Also to thank our execs who have very carefully managed this, and you hear from board meetings like this, how on a daily basis they're on top of this and situations are changing. Reference has been made earlier on how the transformation of services, and Sue and I have seen some of those physical transformations in the last couple of weeks, and just to thank our synchronicity, our estates and our suppliers and everybody else who have acted so promptly in dealing with this and making our services safe for our patients. And I know, Paul, you took the opportunity just this week to see some of those changes at Darlington as well. And I don't know whether you wish to comment on what a transformation that has been to outpatients emergency at Darlington.
The thing that strikes you as you walk around is that clearly some physical stuff is, you know, you can see it, it's there, it's big and bold and it's bright and you can't miss it. But the thing that it continues to amaze me is just the resilience of ordinary people and how far and how they're prepared to go to look after patients. You know, the most unassuming people are just quite amazing in terms of how their attitude is. And it shouts at you when you talk to them. You don't see that in private sector or in other walks of life, in my experience anyway. So that was the...
I just also thank our governors who've been extremely patient and who've kept engaged right throughout the whole process. As Sue said earlier on, they've been briefed on a regular basis, and we have received questions from them on an ongoing basis through our communications, through our briefings. If they have got any sort of concern, they've contacted Warren, and Warren has kept them up to date on how things are changing or to clarify situations with them. But also to thank our board, and you've heard today from the questions that's been asked by our non-executive directors, how they remain absolutely focused, as always, but particularly through this difficult situation of COVID, how we remain very, very confident that what's been done within the organisation is done in the best interest of our patients and their safety. Also to add in, you know, our partners, you know, we took a decision some years ago that we would work as a system across health and social care, primary, secondary care, local authorities, through the ICS and so forth. And some of you might have heard the webinar yesterday, how the system as a whole, you know, has supported each other. All the organisations have come together to deal with the situation. So the North East is a great example of how this has worked and will continue to work during these difficult times. And last but not least, I'd like to put on record our thanks to the community for their kindness and generosity to our staff during these times. I mean, I've seen Facebook, I keep regular contact with it, how the staff are being supported through health and well-being, but also through things like chocolates and pizzas and God knows what else. There's been, oh well. So put on record our thanks to the community, businesses, charities, everybody else who've really come together, and how they've actually come together to support their local hospitals, but the trust as a whole. It's really, really commendable to see that happening, and just sincere thanks to everybody. And just in terms of a communication and briefing, you know, Sue has kept our members of Parliament briefed right throughout the whole situation. She's had regular conversations with all of them, so they're aware of how we're dealing with an organisation. And indeed, I should say that Sue has been commended in the House of Commons on 2 occasions by her leadership in actually dealing with this crisis. But in the last couple of weeks, Sue and I have met with some of the members of Parliament, and we'll continue to meet with them over the next couple of weeks. But they are kept very well informed and detailed informed about the difficulty we're facing, particularly around resources and finance, etc. So everybody has been very well briefed throughout the whole process. So once again, in conclusion, thanks to everybody for their support and commitment in these difficult times. So if there's nothing else on COVID, we will move on. And Michael, there's integrated quality assurance preface. I think it's a verbal up because your meeting was only yesterday.
That's right, Chair. The Integrated Quality Committee met last afternoon, so not much time to get a printed version, but I could give a brief update of the work there. It was a very well attended meeting, full exec representation of senior deputies, and we benefited from the attendance of the Chief Exec as well. The committee received an update from the Trust's executive committees. We received a tabled copy of the annual quality account in advance of its 30-day consultation period. We discussed the national audit, a HIP audit for antenatal and newborn screening, and noted that all the recommendations in that report had been accepted by the executive and will be implemented. The committee discussed the latest performance report in some depth. I won't go into much of it because Carol's covered an awful lot of the issues that were covered there. We did, however, touch on safe staffing and looked at nurse staffing, particularly including interrogating individual wards, and received some very encouraging reports on strong performance in nurse recruitment over the summer. I've mentioned the Falls report already in the question I put to the Chief Executive a few minutes ago. We also received the infection control report and noted an increased incidence of Clostridium difficile and the investigations going on in the Trust for the reasons for that. And finally, we received reports on the annual report on falls and on clinical governance. We received an update on NICE compliance, and finally wound up by reviewing the board assurance framework, or at least those objectives that fall within the purview of IQAC. And the committee was satisfied that the risks and trajectories as updated in that BAF were appropriate and reflected the business of the meeting and the information we had to hand. Thank you.
Okay, thank you, Michael. Then we'll continue, Joanne, with your patient safety experience.
Yes, thank you. The beginning of the report actually talks about COVID, so I won't go over that because it's been well versed. We've had no MRSA bacteremias for the month of July, so that remains at 0 for the organisation up to the end of July. Unfortunately, we have had 1 MRSA bacteremia since then, so that'll show on the next board report. Influenza activity, there is 0 at the moment for the organisation, but we've discussed already that plans are underway in terms of making sure that as many people can be vaccinated as possible, and lots of work streams underway regarding that. The serious incident report, you'll note, and just to highlight that I have included from March to July because I'm very aware that you haven't seen the serious incidents that have been reported within the open board report, so they're all listed there. So if the numbers look elevated, it's for that reason. They're not actually elevated in real terms, considering what we would usually expect to see. We have put a summary of action monitoring against the serious incidents for the first quarter, as we've done some catching up as we're coming out of the surge of COVID. And you can see on the report that we do have some outstanding actions that have gone beyond the date we expected them to be closed. So that will be closely monitored by the Patient Safety Forum on a fortnightly basis, and I'll also continue to report back to the board so that you can see that that comes back on track. Michael's discussed the falls prevention report and the effect of COVID and where we did the deep dive over a 2-month period, and when we compared that to the same period last year, we haven't seen an increase in falls across the organisation, but as has been said, we did pull some really good features from there that we can continue to work on. The antenatal newborn screen and hip audit is also in the report, and as Michael has said, we've got 6 babies who still require follow-up and an action plan that will be monitored through the care group. That was actually a regional audit that was raised for all organisations in the region to carry out that audit, and we were commended as an organisation for the thoroughness of that audit and the results that came out and the actions that came through there. The Mental Health Act annual reports included. The issue to raise in terms of the Mental Health Act annual report is in relation to section 132B forms. That form is where you've formally read the rights to the patient as they go under a Mental Health Act. What we've found is that in 10 cases we can't see that they were read their rights. So there's a bespoke piece of work underway. We've involved TSSQE Valley in that, and they're coming to some educational sessions to help with that. And the patient flow team will put in a process to ensure that we do actually record that we've read people their rights when they're placed under as mental health factor within our care. Moving on to the patient experience measures, the complaints comparative data was what I wanted to pull through there really, that we were shown as being highest for complaints in Q3. The patient experience leaders had a look at that, and actually if you look at the size of the organisation and against per 1,000 bed days and compare us to organisations of the same sort of size, we're on comparative, we're around about the median of the range. It's not to be complacent about that, and you'll note from the charts that they have changed this month. They're going to build SPC charts into complaints monitoring so that we can actually see in real terms if complaints are going off track. And the final thing that I wanted to pull through is the patient experience survey, and that's included in the report, and it's actually very positive. Of the 61 indicators, all of ours were about the same or better than other organisations across NHS for patients accessing the services. We were better than most for 2 questions, and that was how do you feel about the length of time you were on the waiting list before your admission to hospital, and discharge delay due to wait for medicines. Significantly higher for 3 questions, how do you feel about the length of time you were on the waiting list before your admission to hospital, how you would rate the hospital food and the choice of food. And then we had 2 where we were lower than other organisations, and that was from the time you arrived at the hospital, did you feel you had to wait a long time to get a bed, and before you left the hospital were you given written or printed information, both of which are being reviewed at the moment so that we can turn that around. And I'll take any questions, thank you.
Questions for Joanne? Just on page 62 of the technology on page 13, it's the patient incidence, Joanne.
Yeah.
And on the one which is 4377 reference, and in the 4th line it refers to where sepsis was missed. Now I thought we had a good arrangement for actually checking out whether a patient had sepsis when they were admitted or not. So clearly, obviously that's being followed up, I know, but that's just something that...
Yes, and with that one, I think they were clouded in their judgment somewhat because of the patient's other conditions, but absolutely lessons learned with that case. The patient did require intensive care.
Okay, thanks, John. Again on page 64, no, actually it's page 63 on page 14, and it's the reference 7949, and it makes reference to the south of the county. That must be south of the country, would it be?
I'm trying to find the page.
It was, the patient moved to the area from the south of the county. Yes. That was south of the country. Because we wouldn't be treating patients any differently across government.
No, absolutely not.
Okay. And then on page 64, page 15, and it's just duty of candour is referred to. I'm not sure we've seen duty of candour recently as a report.
I think we have. I would have to double check when it came in, but we've had something certainly over the period of COVID, is my understanding. It's been reported through, hasn't it, Joanne?
Yes, absolutely. It has, but I'm not sure that it's coming to the board reports. I'll make sure it comes to the next one. It's still monitored every fortnight at Patient Safety Forum.
And just, do you know offhand, Joanne, because it's still showing pretty good compliance as well, isn't it? So the compliance hasn't progressed over the period.
Okay.
We monitor until it's concluded. The regulation does say to attempt to do it within 10 days. The time when we fall outside of the 10 days is when we're not too sure what's happened with the incident, but we make sure that those incidents aren't closed until duty of candour has been complied with.
I find it's an observation, not a question. It's on page 68, page 19. And while we're being commended by Public Health England, and obviously there's been now a significant change around Public Health England and its management and so forth. And I just wondered, and it's just an observation really, whether there will be consequences for how Public Health England will carry out its role going forward, because obviously certain parts of it, it's just a social hype that it may disappear and have an impact on, our patients being admitted with problems that may be previously prevented, if that makes any sense. But we just got to wait and see how soon.
What we understand is all the duties will move to the new bodies, but not that there'll be any diminution of the duties. So we need to wait and see, I guess. So.
Because again, just listening to the webinar yesterday, and Andy Healy, who gave the presentation around public health, which I thought was excellent in terms of, putting the whole of the organisations in the North East together around public health, and it'd be a shame if we lost any of that. So that's it from me. If there's no other questions on this.
Just the mental health report. The
Yeah,
132B forms have been a bit of a problem, and I think it's down to the numbers that we actually see. I think was there about 13 mental health act cases in the organisation.
There was 20 patients, but 27 mental health acts. Some people were placed on it more than once.
Yeah, so it's not a huge number, so it's very difficult to target which wards they're on. But I think it has been an ongoing problem. It seems to vary. One year it's one hospital, one year it's another. But I think we just hopefully there'll be.
I think moving it to it's not a responsibility for reading patients the rights. It's the responsibility for making sure that those rights have been read, that we're going to focus on this year, and to move it to a 24-hour service and a constant service, which is why I'm going to be negotiating with the patient flow team that if anybody's placed on a mental health section, they go to just ensure that those rights have been read. There will be some responsibility moving from post-falls monitoring to the acute intervention team to counteract their workload, but I think you're right, it's the numbers we see, so the education's there, but some people only see it once in a year, so it's to just make sure somebody's going in to check that all of the paperwork's correct.
Okay, if there's nothing else, will you run into the medical manager?
So very brief, it's just a verbal update. As I told the board last month, there's been a large degree of recruitment of the medical staff over the last few months. Just to report that we have appointed substantively 14 consultants since May, with another 4 being interviewed next week, which 3 are in ED, and 3 will be in radiology, and 3 in respiratory medicine, which I think is very positive.
Very good, excellent. Any questions for Jeremy? Paul?
I'm not Chairman, I've caught all of it, but what I was interested in was how many have gone out the back door or something, you bring them in the front door, how many?
2 pathologists. Thank you. I mean, there were some people who are retiring, who are properly retiring, having been part of our resilience rotas in Bishop Auckland. So Richard Prescott, who has been a long-standing member of the medical fraternity of the organisation, is finally stepping down at the end of this month. But yeah, in terms of substantive employees, we're in 2 pathologists.
Warren? You're out of register sealing?
Yeah, so the board delegates authority to me and my team to seal documents under the secure delegation, and I would normally bring back, but there hasn't been an open board meeting in a period, a quarterly report so that you're aware of how the seal has been used. So this covers the last 2 quarters, the final quarter of 1920, the first quarter of 2021. You can see that there was one use within the final quarter of 1920 for a lease for Innovation House at South Church Enterprise Park, Bishop Auckland, signed by Sue and David. There was no use of the seal in the first quarter of 2021.
Okay, thank you, Warren. And that leads us on into any other business. Does anybody have anything?
Sure.
Yeah, Warren and Oliver. Sorry.
Just to close that action on the action regarding the apprenticeship levy, and I just provide the figures that we have currently utilised £1,681,125.36 of our levy, which represents 42% of the total, given that obviously we've got access to the key areas around nursing frameworks, etc. today, but they are all in advance. So that does represent a sound utilisation level. As I say, we have shared some of that recently this month, so we'll provide an update. That's
Great, thanks, Morgan. Any other business? Would you put one item, and you might have seen in the week ahead, is that Simon Jerry, one of our non-executive directors, has been appointed as chair of Synchronicity Limited and will take up post on the 1st of October. So that creates a vacancy on the board, which will be advertised very, very shortly. So, next item is, our next meeting is on the 30th of September. We will see how this one has gone and obviously evaluate it. But as Warren's mentioned earlier on, it will appear on YouTube and there will be notes of the meeting in due course. And we've just got to see how obviously the social distancing and everything prevails before the 30th of September. And finally, there's no need to exclude members of the public or the press because there's been nobody here. But that concludes the meeting for today, so thank you all very much.